l'homme qui a décrit, travaillé sur les plus communes des causes de l'arthrite de l'enfant, et Kingella kingae. C'est comme c'est une bactérie qui ne pousse pas dans des conditions ordinaires. Il y avait tout un monde que l'on méconnaissait complètement. C'est vraiment lui qui a montré que c'était pathologique. C'est la première cause d'arthrite chez l'enfant, extrêmement. Et on fait un travail collaboratif avec lui, puisqu'il va venir ici pour conséquence toutes ces souches, très grande chance. Il y a un spectre de souches et une connaissance sur cette maladie qui est unique. Et comme il est allé de la clinique jusqu'à la biologie, il est capable d'avoir une synthèse tout à fait extraordinaire. Parce que c'est très content de le faire.
Merci beaucoup, Professor Mahmoud. It's both an honor and a pleasure to be here today. And I have to thank again Professor Baul and his team for their kind invitation to join them for a short sabbatical period and give this presentation. And the title of the presentation is Kingella kingae, an emerging pediatric pathogen. What do I mean by emerging pathogen? Well, I believe that emerging pathogens are those microorganisms that actually more people have received their professorship than patients have died because of them. So if this is an accepted description of the word emerging, well, I believe, yes, Kingella is an emerging pathogen. And you probably know very well that infections of the skeletal system, septic arthritis and osteomyelitis are very disabling diseases in children. If these diseases are not promptly diagnosed and adequately treated, well, complications will follow, even death, and in any case, permanent orthopedic sequelae are quite common. Obviously, isolation of the causative pathogen is crucial in order to confirm the disease and establish the right antibiotic therapy. However, it should be paid attention to the fact that all over the world, about 1/3 of all cases of suspected septic arthritis or osteomyelitis remain bacteriologically unproven. That is, cultures fail to grow the microorganism. It was in the late 80s when I and many of my colleagues working in southern Israel became a little bit uneasy by the fact that we were not culturally isolating the microorganisms in too many cases of skeletal system infections. So at that time we decided to do the following. Once we got a synovial fluid aspirate, we decided to culture it onto conventional culture medium. And in addition, to seed part of the exudate into a blood culture vial. Well, very shortly after the adoption of this very unorthodox approach, we started to isolate a very peculiar gram-negative coccobacillus here on the left side, showing the typical morphology consisting of short chains of plump coccobacilli. You can see on the right the electron microscope photograph of the same pathogen. Well, actually, this pathogen was actually first described in the 60s by Elizabeth King, and the microorganism was named after her. Kingella kingae was actually isolated very rarely from human cases of disease, septic arthritis, and mostly endocarditis. But the number of cases described up to the end of the 80s would be counted with the fingers of 2 hands. Well, the microorganism has a very specific biochemical behavior. He is beta hemolytic. The oxidase test is usually positive and utilizes glucose and maltose. Going back to our first experiences in the culture of this microorganism, out of the first 12 cases of septic arthritis caused by Kingella detected by the blood culture vial, only 2 actually yielded the microorganism in regular solid medium. However, when we took fluid from the positive blood culture vial and subcultured it onto the same solid media, the microorganism grew wonderfully. So, we assume that the problem is that synovial fluid is a very hostile medium for fastidious Kingella microorganisms because, oh sorry, I have to correct the now it's much better. Well, we believe that these detrimental factors are basically complement antibodies, leukocytes, and maybe antibiotics the patient is receiving. When we take a small amount of synovial fluid exudate from the patient and dilute it into a large volume of nutrient broth, we'll actually be diluting also the concentration of antibodies, the concentration of antibiotics, giving the organism a chance to grow, because we are reducing the concentration of detrimental factors below what I can call the MIC, the minimum inhibitory concentration. Well, and here you have it. Once dilution has occurred, Kingella will grow wonderfully. Well, in our first clinical experience published long time ago, Kingella appeared as the most common cause of septic arthritis in children below the age of 2 years. And the experience in France that followed also showed very, very close numbers, indicating that Kingella was overlooked for many years. And when using the right method, either the Bactec blood culture vials or the bacterial nerve blood culture vials, you are able to recover the microorganism without much difficulties. And this is not the end of the story, because in recent years, nucleic acid amplification techniques have added to our knowledge of the microorganism and made a substantial contribution to its detection. Here is a study by a French investigator, Larry Borde. I believe he's working in Paris. And when he obtains exudates from 89 children with presumable septic arthritis and actually used the blood culture vial to recover the microorganism. Out of 40 culture positive out of 36 positive vials, Kingella was recovered in 7, which is approximately 20%. However, he used the same synovial fluid samples to perform PCR, looking specifically for sequences specific to Kingella. And he found additional 24 cases, adding to 31, representing 1/3 at least of all cases of septic arthritis. So if you combine cultures and PCR, you can detect a lot of Kingella which could have been missed by regular cultures. Well, we have been using in southern Israel the blood culture vial technique since 1988, I believe. And so far, we have diagnosed Kingella infections in 136 patients. Last one, a few days ago. Well, if you look at the seasonal pattern of Kingella, you will discover that most cases occur at the end of the year, between the month of July and December. The age distribution of cases of invasive Kingella infections is very, very peculiar, resembling that of Haemophilus influenza type B before the introduction of the universal conjugate vaccine, Sedadir. below the age of 6 months, cases of invasive Kingella are extremely rare. However, after the age of 6 months, the number of cases suddenly increases, and the story is plus minus over after the age of 3 years. Actually, 96% of all cases are detected in children younger than 3 years of age. By the way, among our 136 cases, only one adult patient would be found with bacterial endocarditis. This is very suggestive and very interesting also. Well, now I'm going to show a few data in which our own cases as well as other Israeli cases were combined. This is a review published about 2 years ago in which we gathered 313 cases from all over the country. And you can see that we divided the population of patients into 2 groups. Patients, actually children, who had been previously healthy, no underlying conditions, no immunosuppression, no cardiac valve defects. And you can see that among these children, young infants and children up to the age of 3 years were overrepresented. Children at the age of 3 or 4 years were actually a very small minority. However, if we move to the population of patients with predisposing conditions, immunosuppression, cancer, chronic renal failure, etc., steroid therapy, well, the age distribution of patients is totally different. Young children are underrepresented, the green and this pale clear blue, while older children are overrepresented in the center. So, if you see a case of invasive kingae in a child older than 3 years of age, this can be considered a marker for an underlying either diagnosed or undiagnosed disease, maybe immunosuppression, cardiac valve pathology, etc., etc. Well, among the 136 cases already diagnosed in southern Israel, the distribution according to clinical symptoms was as follows. The skeletal system was actually the largest portion of the pie. Septic arthritis, osteomyelitis, a combination of both septic arthritis and osteomyelitis, abortive skeletal infections, tenosynovitis, etc., represented the vast majority of cases. Another large portion of the pie is represented by occult bacteremia, meaning by that the mere passage of the microorganisms through the bloodstream without a focal infection, just bacteria, no focus, no skeletal infection, no endocarditis, just the microorganism circulating in the bloodstream. And by the way, endocarditis, which is overrepresented in the medical literature because of the severity of the disease, represents only a tiny proportion of cases of invasive Kingella infection. So endocarditis is not a common presentation of Kingella. Skeletal infections and just bacteremia are much more common. How do patients with invasive Kingella appear? Well, they usually present with no fever or low-grade fever, and in general terms, they look quite well. Usually, a single focus of infection is seen in these patients, as opposed to Staphylococcus aureus infections or Haemophilus influenza infections, where many foci of infection in the skeleton, in the central nervous system, could be seen simultaneously. This is not the case for Kingella. Kingella, usually we find a single focus. The disease requires a very high index of clinical suspicion because these children do not seem to be too ill. Fever is not very high. Leukocytosis, presence of large number of white blood cells in the circulation, is rare. So, in many cases, these children are dismissed as patients with simple viral respiratory infections. No cultures are obtained because it seems that there is no indication for obtaining a blood culture. The fever is not high enough, acute phase reactants are within normal limits. So I believe that we are missing all over the world many cases of invasive Kingella kingae infections, especially bacteremia. And even if you perform an aspiration of the synovial fluid in cases of arthritis, the overall picture there is not impressive at all. Low number of leukocytes, normal biochemistry, and you can actually miss the presence of the microorganism. The ground state is usually also negative. Well, in cases of septic arthritis or osteomyelitis due to Kingella kingae, usually the long bones or the large joints are involved, the humerus, the radius, the ulna, the shoulder, the elbow, etc., of course the hip, knee, ankle, etc. Usually is this distribution, this anatomical distribution of foci of infection is quite similar to that observed in other microorganisms such as Staphylococcus aureus, etc. However, in cases of Kingella kingae, there is overrepresentation of peculiar sites which are rarely or exceptionally infected in diseases caused by organisms other than Kingella. For example, the sternoclavicular joint, or the sternum, or the metacarpophalangeal, or the calcaneus, or the talus. This presentation, this rare involvement, or this involvement which is rarely seen in patients, should suggest in young children the possibility of a Kingella kingae infection. Spondylodiscitis is the infection of the intervertebral disc, this cushion which separates two contiguous vertebrae. Well, you can see on the left in the MRI that the disc is separating the lumbar vertebra L4 and L5 is very, very narrow. The disc has collapsed because of the infection. Compare the space with the space between upper vertebrae. It's clear that the height of the space has been much reduced by the inflammation. Okay, this presentation is typical of young children. They present with low-grade fever or no fever at all, but refusal to sit or walk or stand. If you touch the affected area, this will be very painful, and despite the very, very ugly appearance of this MRI, cases resolve with antibiotics and sometimes even without antibiotics. So the overall prognosis is good. Kingella kingae endocarditis is another problem. Actually, Kingella stands for the K of the HASEC acronym. This group of organisms of buccal or odontogenic origin is collectively responsible for 5% of all cases of endocarditis. H stands for Haemophilus, C for Cardibacterium. Well, the K is Kingella. And Kingella kingae endocarditis is a different disease because not only young children but also adults may be affected. Usually they have a predisposing congenital malformation of the valves or a rheumatic disease or something else which is perturbing the circulation inside the heart. Very often these patients will develop very serious complications. including cerebrovascular accidents, as shown in the lower picture. You can see that one of the arteries, the one that should be here, running in parallel to this one, actually does not exist. It has been obstructed by a thrombus, and this entire area of the brain has suffered a very serious infarction. Well, these complications are very, very common. And there is a clear difference in clinical terms between the behavior, the biological behavior of patients with endocarditis, a severe disease, and those with skeletal infections or bacteremia that usually present with a very benign picture, and their overall prognosis is remarkably good. Well, we have conducted a few studies in which we decided to explore where does Kingella kingae come from. And we ended up with the following results. Kingella kingae is part of the normal flora of the pharynx, of the oropharynx, not of the nasopharynx of young children. And actually, there is a very clear overlapping between the age of carriage of the organism in the pharynx and the age in which most cases of invasive infections can be seen. And you can see that, well, in very young children, there is no Kingella kingae in the pharynx. Maybe because of that, there is no Kingella kingae in the blood or in the skeletal system. But between the ages of 6 months and 4 years, the prevalence of the organism in the pharynx is around 10%. And in older children, you can see a decline in the prevalence. Okay, this carriage of the organism in the pharynx is just colonization. No signs or symptoms of disease. The organism is there as part of the normal flora, and that's it. No associated disease, no symptoms. In a later study, we made zoom in the younger age, and again, before the age of 6 months, the organism was not there. At the age of 12 months up to 24 months, the prevalence reached a plateau around 10% again, and after the age of 24 months, a decline in the prevalence of the organism in the pharynx, as we have already seen, a decline in the incidence of invasive infections caused by Kingella kingae. Well, the presence of the organism in the pharynx has a dual importance. On the one hand, as we're going to see in a few seconds, this is the way for the organisms to be easily transmitted from child to child, from person to person, through saliva droplets, through respiratory secretions, because the organism is in the pharynx. So it's very easy to establish chains of person-to-person transmission between children. And if the children are plus minus healthy, well, nothing will occur. And these chains of transmission are endless. Endless in time, because the organism probably originated many millions of years ago. And these chains are also endless in the space, in the geography. Well, usually, children acquiring the disease will become colonized and will remain healthy. However, here and there, a child acquiring the disease will develop an infection. Okay? Southern Israel is a very peculiar place, not because I'm living there, but because we have two very different populations living side by side. On one hand, a large Jewish population, mostly urban, and a large minority of semi-nomadic Bedouins who are in transition from their ancient culture to permanent settlement. However, the two populations live side by side with very, very minimal contact. They live in different towns, they go to different schools, to separate schools, and there is not much contact between the young Jewish population and the young Bedouin population. And actually, we examined the clones as determined by pulse field gene electrophoresis of Kingella organisms colonizing Jewish children and Bedouin children at the bottom. And we found profound differences. Actually, the two populations were colonized by totally different microorganisms. Clone K, which is extremely common among the Jews, was extremely rare. For the perspective, I believe you can see it. Okay, Clone K actually is extremely common as a colonizer among the Jewish population and extremely rare among the Bedouins. Follow this peculiar strain. I am going to devote quite a lot of time to describing many of the details of the dissemination of this particular clone. In any case, this bacteriological evidence confirms the social isolation of the two populations, the Jews and the Bedouins living in southern Israel. Each ethnic group has its own Kingella kingae strains. In this study, we examined the similarity between Kingella kingae isolates, again by pulse field gene electrophoresis, of organisms isolated in a single neighborhood in one of the Bedouin towns. And you can see actually that each isolation is represented by a star, and each color represents a different pulse field gene electrophoresis pattern. You can see that there is clustering, geographic clustering of the same clone in certain areas, indicating probably that close person-to-person interaction between children is responsible for transmitting specific clones within social networks. And this is the case also for daycare centers. You are well aware that daycare centers are special places from the epidemiological point of view, and a lot of transmission of organisms, viruses, bacteria, parasites occurs due to poor hygienic behavior of young children and crowding a lot of children in a small place. Well, in this study we actually examined longitudinally over time colonization by Kingella kingae in a daycare center. And actually what we can see is that overall in an 11-month follow-up, 3/4 of all daycare center attendees carried Kingella kingae at least once. And at any given moment, 1/4 of all children were colonized by Kingella kingae. A much higher prevalence of the organism than in a regular population not attending daycare center. And then we perform, of course, pathogen electrophoresis. Well, you can see that this carriage of Kingella kingae was a very dynamic process, characterized by frequent turnover of strains. Here, each strain is represented by a different color, and you can see that the red clone was very common at the beginning of the study, and at the end of the study, clone K, here in purple, actually took over and disseminated very quickly among the two cohorts of children attending the same daycare center. And again, clone K is here. By the way, we have also observed, as well as Americans and French people, clusters of disease among daycare center attendees. It's not just benign transmission. We have detected clusters of disease in daycare centers. Here is a very gross description of a cluster of cases occurring in one daycare center in Israel. Within 2 weeks, 3 cases of osteoarthritis caused by Kingella were diagnosed, and actually the 3 cases were caused by the same microorganism. We obtained throat cultures from all daycare center attendees, and it was very clear that the microorganism has disseminated all over the daycare center, indicating that this microorganism was a very successful colonizer as well as a very virulent strain. This is one part of the story. In another study, we have actually examined Kingella organisms recover from the throat of children with invasive infections and compared these isolates when the microorganisms isolated from the blood of the same children. It was very clear that in these 3 children, the blood isolate and the pharyngeal isolate were identical, indicating probably that the upper respiratory tract, the oropharynx, is actually the smoking gun from which these microorganisms enter into the bloodstream, disseminate through the circulation, and penetrate bones, joints, or invade the endocardium. And we have recently finished a study in which we typed using pulse field gel electrophoresis our large collection of 181 invasive Kingella isolates obtained from all regions of Israel, 181. We overall found 32 different distinct pulse field gel electrophoresis clones. However, 5 clones, just 5 clones out of the 32 were responsible for almost 3/4 of all cases, indicating that these are epidemic clones, very successful invaders, while the remaining 27 clones actually share the spoils, the 28 plus minus percentage of cases. So these very interesting strains invite us to further examine these microorganisms. And again, pay attention, clone K was the most common one among invasive strains from all over Israel. Going back to southern Israel, well, it's a kind of tourism. You are moving all over Israel, now we are returning to the south. And what do we see here? We see that the epidemiology of invasive Kingella infections is different between Jews and Berlin children. The overall incidence among Jews is double than the incidence among Berlin children, despite the fact that children of Berlin origin are living in crowded conditions, poverty, low socioeconomic standards. And despite of that, well, the incidence of invasive infections is relatively much lower than that of the more affluent Jewish population. Also, Jewish children with invasive infections were significantly younger, and if you look for clone K, were overrepresented among cases occurring in Jewish children and quite rare among the babies. Actually, if you take out clone K from the figures, the incidence of disease will be approximately the same among Jews and babies, indicating probably, or at least suggesting, that this excess of morbidity observed among Jews is at least partially caused by the dissemination of clone K in the Jewish population, a clone again which does not almost exist more today. Well, we also are conducting a few studies in which we are exploring the possibility that our strains, our clones, isolated in Israel, are also represented in other regions of the world. In this study, actually, we performed MLST in a large collection of green microorganisms from Israel, red microorganisms from France, and a few representatives from Norway, the former USSR, and the USA. And basically, you can see that a few clones are represented not only in Israel, but also the same microorganisms or very closely related microorganisms are also causing disease in the USA and France. The same for this one. What about clone K? Is here well represented, of course, among the Israeli strains and also represented among the French strains. So beware, French people. You have the K clone of Kingella here, and it's here to stay. I think. And by the way, we decided, based on the fact that we have a large collection of strains, isolated from a lot of patients, to see if all Kingella microorganisms were created equal. Well, they were not. And some Kingella organisms show very clear tissue tropism, affinity for the invasion of specific fossa. For example, clone K, again, clone K is associated with bacteremia, pure bacteremia. Less commonly, it enters the skeletal system. Clone N is very rare in the pharynx, probably unable to colonize for a long period, so it's not detected. However, it causes invasive infection. It's very rarely isolated from the blood, indicating that the organism is unable to persist in the bloodstream. However, is overrepresented among skeletal infections, indicating it has affinity to bones and joints. And finally, clone P, and this is the pulse field generator phoresis configuration that the microorganism shows a very, very strong and very suggestive affinity for the endocardium and is overrepresented in Israeli cases of endocarditis. I would like to summarize a little bit of what I know about Kingella kingae. It has been well established that the microorganism is able to colonize the upper respiratory tract, the oropharynx, without symptoms. This microorganism has a very strong toxin, which is called the RTX toxin. And this toxin is deleterious to the pharyngeal epithelium, is deleterious to the leukocytes and to synovial fluid cells. So apparently this hemolyzing, this toxin, is somehow participating in the pathogenesis of the disease. We believe that the microorganism is able to use this hemolyzing somehow to facilitate colonization of the upper respiratory tract. We have seen a lot of upper respiratory tract infections occurring simultaneously with Kingella kingae infections, for example, herpes simplex virus, stomatitis, etc. So we believe that a concomitant viral infection damages the pharyngeal epithelium, enabling the microorganism to penetrate into the bloodstream. Otherwise, the microorganism itself may damage the same epithelium while using the RTX toxin. Once in the blood, the microorganism will cause bacteremia. And because of its affinity to the skeletal system and the endocarditis, circulating bacteria will rapidly enter into the bones or joint or invade the cardiac valves. In more rare cases, the microorganism may be aspirated to the lower respiratory tract, causing pneumonia or lower respiratory tract infections. Probably the peculiar epidemiological curve of both colonization and invasive infections can be explained in the light of the immune response. We have seen that in children younger than 6 months of age, colonization does not exist. Infection does not occur. On the other hand, they show high levels of IgG against Kingella kingae. We believe that these levels are derived from the mother's circulation. So the mother is able to protect the young infant during the first 6 months of age against Kingella kingae infections. There is nothing new here. It's the same against pneumococcus and many other pathogens. However, after the age of 6 months, the level of antibodies is nadir, very low, where it's an excellent opportunity for Kingella kingae organisms to colonize the respiratory tract, no antibodies around, and probably invade. You can see at the same age an increase in the number of cases of invasive infection. And after the age of 18 to 24 months, there is a sudden increase in the levels of antibodies to the microorganism, and as a mirror image, a decline, a decrease in the incidence of infection. So we believe that the immune system is playing a very crucial role in protecting young children from infection. This may explain why patients with immunodeficiency, even if they are adults, are susceptible to Kingella kingae infection. And finally, it's time to treat our patients. Well, we are very lucky because Kingella kingae is usually very susceptible to antibiotics which are given to children on an empiric basis just because they have fever and maybe symptoms of skeletal system infection. So, the microorganism is usually very susceptible to penicillin and cephalosporins. Here and there are a few isolates which are producing beta-lactamase enzymes, but these isolates are quite rare. On the other hand, the microorganism is always resistant to glycopeptides such as vancomycin, and also clindamycin tends not to be effective in about 1/2 of cases. With the exception of patients with endocarditis, which usually run a very severe course, or other syndromes and diseases caused by Kingella kingae are usually very benign, and no cases of complications or chronicity or long-term orthopedic sequela have been ever described in cases of Kingella kingae. Okay, with this very optimistic sentence, I believe I have to finish my talk. Thank you very much for your patience. And if you have a few minutes for questions, please.
Do you have any external factors that you can identify that mean that somebody with carriage of Kingella may have an infection?
Well, we are actually finishing a study in which we try to identify risk factors for carriage. The strongest risk factor clearly was age, followed by daycare center attendance. These two factors were probably the only ones clearly identified in the study as associated with carriage of the microorganism, which is quite similar to what has been described for pneumococcus, Staphylococcus, Varicella, and other respiratory pathogens. Kingella is a respiratory pathogen, and I believe that it's following the rules of other microorganisms colonizing the respiratory tract.
Yeah, but did you identify any
cofactor?
No, any cofactor to make that you are infected when you are colonized?
Well, I believe that even if we haven't conducted enough work, that everything depends on factors encoded in the bacterium, such as chrome K, which appears to be the hyperviolent one, as well as factors depending on the host. For example, children with Kingella infections usually have signs of upper respiratory infection. We have found a lot of children with primary herpetic gingival stomatitis. So I believe that co-infections with viruses, especially those viruses, varicella was causing after in the oral mucosa, these viruses, which are probably damaging the respiratory tract, may facilitate penetration of Kingella kingae from the pharynx, where they sit quietly, into the bloodstream.
And then there is a seasonality of arthritis?
Yeah, there is a kind of seasonality in Kingella kingae infections, all of them. And so I showed you again, try to find myself. I've lost a little bit. Yes. Between July and December, most cases.
July and December. Okay,
Jumping, yes.
And if you separate arthritis from...
We haven't done it because we do not have enough cases. The power is not, the physical power is not strong. We only have 136 patients to be divided in southern Asia into 12 months. This is not the power. But grossly, the end of the year is the Kingella kingae season, if there is such a thing. Any other questions?
Well, we've had plenty also since we do real-time PCR.
La différence, c'est que I do not in Marseille, we do not have so many bacteria. We do have arthritis, of course, as you described, but the one difference seems that we do not have bacteria. Otherwise, we use the same bacteria system as well.
And no very few.
Yes.
It seems to be a little bit different.
Yes, but I believe that this is a technical problem. For example, in Israel, in southern Israel, the entire population, Jews and Bedouins, are covered, all of them, by our health insurance system. So when a child, a young child, presents to the pediatric emergency room of the hospital with fever, any fever, or even a history of fever, the blood culture is obtained. If you follow the American guidelines for obtaining blood culture, unless the fever is high and leukocytosis is present, children will not undergo a blood culture. So I believe that if you use the regular criteria for obtaining blood cultures, you are going to miss almost all cases of Kingella kingae bacteremia because the fever is not very impressive, because the white blood cell count is usually within normal limits, so why to obtain a blood culture? It looks like a viral infection. On the other hand, if a joint or a bone are affected, well, these children will be hospitalized and the diagnosis will be made. For cases of bacteremia, I believe that we are missing them all over the world, even using the same blood culture system.
Is this with bacterium known the overbalance?
Good question. I don't know. I don't really know. Nobody has explore the possibility that this is a zoonotic infection, or at least other pets, not only human pets, but also other pets, are actually colonized by the microbe. No, it has never been done. Never. I believe that's it, unless you have... Okay, thank you very much.